Welcome to another EduMed video, and this is another in the series of airway pressure release ventilation videos, and this one is talking about how to wean someone off APRV who's having a resolving hypercapnia, i.e. their PCO2 is improving. As with the last few talks, we will go through the physiology of APRV. We'll talk a little bit about the patient with resolving hypercapnia, and then the settings that you would change when the PCO2 is getting better with the patient. It's probably worth revisiting what oxygenation depends upon. Again, I keep saying, go and see my previous videos, the ones on the basics of ventilation, and then the previous videos on APRV to get a better background of this. But essentially, oxygenation depends upon FiO2. The alveolus being open, gas exchange is dumb. It doesn't know whether it's expiration or inspiration. As long as the alveolus is open and there is blood flow going to the alveolus, there will be gas exchange and therefore oxygenation. Now, the disease process that usually causes patients to become hypoxic and require positive pressure ventilation is an interference of the alveolar blood interface. That's usually infection with pus and inflammation, or it could be fluid with things like pulmonary edema secondary to acute left ventricular failure. These are the things that we try to improve with antibiotics, diuretics, and chest physio. And therefore, as the patient comes along their intensive care stay, hopefully that alveolar blood interface becomes better, and therefore their oxygen requirements and ventilatory requirements reduce. CO2 depends on minute ventilation and alveolar perfusion. Minute ventilation is a function of tidal volume and respiratory rate, and alveolar perfusion is really just a matter of good right ventricular outflow and good cardiac output. The special thing about APRV is that we're trying to maintain a column of air open from the level of the ventilator through the endotracheal tube, through the trachea, the bronchi, and all the way into the bronchioles and the alveoli. So everything remains open. And therefore, if you imagine the alveoli, which are constantly being washed with deoxygenated blood from the right ventricle that's high in CO2, those alveoli are going to start to accumulate a high concentration of CO2. Now, if you've got a continuous column of air, and at the ventilator side you've got no carbon dioxide, you can imagine that you'll get some passive diffusion of carbon dioxide from the level of the alveoli through and into the ventilator. So in addition to the bulk flow of gas, which is the majority of the CO2 removal and pretty much the main form of CO2 removal in passive ventilation with you and I, or those with conventional ventilation on a ventilator in intensive care, you will only really get bulk flow of gas. In APRV, you also add in this additional diffusional CO2 removal as well, which can improve the efficiency of CO2 removal in these patients. Always think of APRV as essentially extreme CPAP. The main thing that we're trying to do is to recruit up as many alveolar units as possible to take part in gas exchange. Now, as with any disease process in the lungs, what it does is it makes the lungs thick, sodden, and therefore difficult to change the volume for a given change in pressure, i.e. compliance. You can see here on this graph essentially what you see in real life when you blow up a balloon. When you're blowing up a balloon from scratch, you find that to begin with, it's really difficult for it to expand for a given breath. Then, after a little while, you find that with each breath, you get a big change in volume. And then, as the balloon starts to fill up to its limit, it then again becomes very difficult for there to be a change in volume in the balloon for a given pressure that you provide with blowing up the balloon. And that's exactly what this graph shows. If you look at the solid line, until the point of the lower inflection point, for each breath that you try to push into the balloon, it's quite difficult, but then suddenly it becomes very easy. And that's that steep upward line that you see in the curve. And that is where a very small change in pressure gives a large change in volume. That's where you want to try and be to try and reduce the work of breathing. Now, in a very severely diseased lung, what you often find is that the compliance of the lung has reduced significantly. As such, by using CPAP, by increasing the pressure, what you're doing is you're moving along that x-axis, and therefore the patient starts off in the middle of that compliance curve and therefore still is able to take breaths easily. Intuitively, you know that's true, because if you imagine driving in a car at say 5 or 10 miles an hour and stick your head out the car, you suddenly find that your lungs fill up with air, as it's rushing past the car, and therefore you actually find it a little bit easier to breathe. Now, if you were to keep accelerating with the car, you find that suddenly your lungs get overfull with air, and then it becomes more difficult again to breathe. And that's where you've reached the upper inflection point. Now, if APRV was just about oxygenation, what you would do is you'd have a high pressure to open up as many alveolar units as possible. The problem is you get nothing for free. And in ventilation, by increasing the CPAP and just having CPAP, you find that it might not be enough to get rid of all the CO2 that the patient is generating, especially if they're septic and they're in a hypermetabolic state. And this is where the releases come into play. By having a release after a certain period of time, that certain period of time being the time high, that release allows a bulk flow of gas to come out. So in addition to the diffusion that you get during your time high, where you're at your high pressure, you also get a release of gas, which gives a big flow of gas to come out. And that aids with CO2 removal. So what can you set in APRV? There's only really 5 things that you can set. The first is the fractional inspired concentration of oxygen. The second thing is the pressure at the high level and the amount of time that you're at that high level. The pressure at the low level is always set at 0 or as near to 0 as you can. And the reason for that is you want to try and maximize the gradient of the pressure gradient so that you get the maximum amount of gas released with any one release phase. And the way in which you regulate the amount of pressure that's left in the lung is by reducing your time at the low pressure. If you imagine you've only released the pressure for 0.1 of a second, most of the pressure is still going to stay in the lung before the next high pressure point comes. So the lungs aren't going to deflate that much. The longer your time low, the more of the lung deflates, and therefore the less pressure is left within the lungs. So the way in which you control your end release pressure, which you can think of as like your PEEP, is by changing the time that you allow for the release. And that's why in APRV we talk about these very short periods of time that you release for, so 0.2, 0.4, 0.5 of a second. And that's why it's only a relatively new mode of ventilation, because it's only more recently that we've been able to have these very special valves that can release for a very short period of time and then close again. And these valves are even more special because they also allow patients to breathe spontaneously at those high pressures that you've set, the peak or high pressures. So as hypoxia resolves, what you want to try and do is you want to try and sorry, that shouldn't say hypoxia, that should say hypercapnia. As the hypercapnia starts to resolve, what you want to try and do is increase your T highs. What does that do? Well, it reduces the number of releases, so the number of bulk flows of gas that you're getting. Why would that improve things? Well, You could, as the hypercapnia, i.e. the amount of CO2 resolves, you don't need as many of those releases. The patient's spontaneously breathing enough to be able to get rid of that. Similarly, as the hypercapnia, the high CO2 reduces, you can reduce the P high because the compliance is improved and you don't need as big a release of volume. And as long as your hypoxia has resolved as well, you can start reducing down your P high. What you're aiming to do is the so-called drop and stretch. You want to drop down the high pressure, the P high, and you want to stretch it out, so increase the T high, so reduce the number of releases per unit time until you get to a point of pure CPAP. Most people, once they start weaning off APRV, will move on to a conventional mode of ventilation, such as a CPAP with pressure support. But you could theoretically just continue to drop and stretch your pressure high and your time high until you get to a point where you're just continuously on CPAP. We often don't do that because patients can be quite weak after a stay on a ventilator, especially with severe respiratory failure, and as such may need a bit of pressure support, which is a bit of additional pressure that patients get with taking a breath in, just to help them and to not tire them out too much. Always remember the lung compliance changes as time goes on. As your treatments like antibiotics and removal of fluids start to take effect, the lungs become more springy, they become more compliant, and therefore they need less pressure to start with to stay within that inflection point period between the lower and upper inflection point. And you might well find that having that 30 centimeters of water that you needed at the start as your P high, because the lungs were just completely consolidated, actually drops down to only needing about 5 or 10 centimeters of water pressure to remain in the middle of that inflection point of the compliance curve. So always reevaluate your patients and think about what the perfect pressure for that patient is. So if you've got improving hypercapnia, you want to try and reduce the number of releases per unit time. How do you do that? By increasing your time at the high pressure. You can also start to reduce down your pressure high depending upon where the patient is on their compliance curve. As the lung becomes less consolidated, less infected, or less sodden with water, the compliance will improve, and therefore the amount of pressure that you need will reduce down at baseline, i.e. your PEEP level, and you will remain in the middle of that compliance curve. The overall strategy for weaning off APRV is the so-called drop and stretch. Drop the pressure high depending upon the compliance of the lungs, and increase the time that it's at the high pressure, i.e. reducing the number of releases per unit time. As the patient's compliance improves, they can breathe more, they have higher tidal volumes, and therefore they don't need as many releases to help with the bulk removal of CO2. I hope that was a useful video, and if you've liked this video, please check out the rest of the series on APRV and on different modes of ventilation. Please like this video, please subscribe to the channel and hit the bell notification, because there's going to be a lot of videos over the next couple of months on intensive care.